Okay, let's look at our roadmap for today. We're going to move logically through 6 key areas, starting with sepsis management in bundles, then viral pathogens in surgery, universal precautions, preoperative and surgical techniques, antibiotic stewardship, and finally, antibiotic formulary profiles. Right, let's dive into Module 1, Sepsis Management and Bundles. Our focus here zeroes in on the Surviving Sepsis campaign. This was spearheaded back in 2002, really to standardize how we diagnose and treat sepsis, all with the ultimate goal of reducing mortality. So, the absolutely crucial point here is defining exactly what triggers our acute interventions in the first place. The resuscitation bundle is a set of evidence-based objectives specifically designed for patients presenting with severe sepsis, septic shock, or a highly elevated lactate level, and by that we mean greater than 4 millimoles per liter. The moment you see these physiological triggers, the clock starts ticking. And that brings us to our most critical clinical metric, 6 hours. You have exactly a 6-hour window to complete the resuscitation bundle. It's a strict, absolute deadline to reverse tissue hypoperfusion and stabilize that patient before multi-organ failure becomes completely irreversible. No exceptions. To make this happen under pressure, the UK's Sepsis Trust brilliantly simplifies these life-saving interventions into the Sepsis 6 protocol. It neatly divides the workflow into 2 halves. First, the Give 3. We push an IV fluid challenge, we administer IV antibiotics, and we give oxygen, all while closely monitoring urine output. Then there's the Take 3. Before we flood the patient's system with antibiotics, we absolutely must take blood cultures, a full blood count, and that all-important lactate level. It's this perfect cause-and-effect clinical workflow. Moving on to Module 2, let's see how this fits into the broader picture of infection control. We're shifting gears from bacterial, physiological disasters to the specific bloodborne and respiratory viruses that surgeons face right there in the theater. Think about the 3 major bloodborne pathogens: hepatitis B, hepatitis C, and HIV. They all have distinct transmission and progression profiles, but all 3 are transmitted via blood-to-blood contact. That makes intraoperative needle sticks a massive occupational hazard for us. Now, hepatitis B cases are often completely asymptomatic, which means surgeons must actively know their immune status and ensure they're vaccinated. Hepatitis C, on the other hand, often becomes chronic, though it is potentially curable with treatments like interferon alpha and ribavirin. And then there's HIV. It's a retrovirus where, if left untreated, progression to AIDS occurs within 2 years in up to 35% of patients. Treatment involves HAART, highly active antiretroviral therapy, which inhibits reverse transcriptase and protease synthesis. It suppresses the virus, though it doesn't actually clear it. Historically, we also know this virus increases the risk of opportunistic neoplasms, like Kaposi's sarcoma, a condition first described by Maurice Kaposi way back in 1872. Alongside those bloodborne risks, we also have to manage strict chronological protocols for contagious respiratory diseases, like COVID-19. The timeline here is non-negotiable. It starts 10 to 14 days prior to surgery with mandatory preoperative cocooning for elective patients. Then exactly 2 to 3 days prior, we require mandatory swab testing. This extremely tight window isn't random. It's designed specifically to account for the virus's incubation period, which ranges from 1 to 14 days. We have to ensure the patient is genuinely negative before they enter a highly vulnerable postoperative state. Because honestly, if a surgical patient does contract SARS-CoV-2, the postoperative complications can be just devastating. The pathogenesis involves a highly dangerous cytokine storm mechanism. This cascade can rapidly precipitate ARDS, acute respiratory distress syndrome, as well as multi-organ failure, septic shock, and really dangerous hypercoagulable states. It's exactly why those strict preoperative timelines, hand hygiene campaigns, and pharmacological supports like dexamethasone and hydroxychloroquine became so incredibly central to surgical safety. Which brings us logically to Module 3, Universal Precautions and Safety. How do we actually physically protect the healthcare team from these severe pathogens we've just been talking about? Well, the CDC and NHS guidelines outline a very strict physical barrier protocol. You need a full face mask or spectacles, plus fully waterproof disposable gowns. This is especially critical during seroconversion. And notice the footwear rule? Boots must be worn instead of clogs. Why? Specifically to avoid catastrophic injury from dropped sharps. We also mandate double gloving. And a pro tip here, wearing a slightly larger size on the inside is generally more comfortable. On top of that, we only allow essential personnel in the theater, and we demand absolute, total respect for sharps. They must be passed safely in a kidney dish to prevent accidents during what should always be a meticulous, controlled operative technique. But let's be real. What happens when those physical barriers fail? Statistically speaking, needle sticks are most common on the non-dominant index finger, and a hollow needle injury carries by far the greatest risk. If contamination does occur, you immediately initiate this emergency response sequence. Step 1, wash the area under running water. Step 2, report the incident immediately. Step 3, strictly follow your local policies for post-exposure antiretroviral treatment and occupational health testing. Do not wait around. All right, let's transition into Module 4, pre-operative and surgical techniques, because infection control isn't just about protecting the staff, right? It's heavily about practical patient preparation and the surgical technique itself. Take the precise timing of skin preparation, for example. If hair removal is required, it must be done immediately before surgery, right there in the operating theater. If you shave the patient the night before, you literally double the clean wound surgical site infection rate. Double it. Why does that happen? Because the minor microscopic skin injuries from the razor significantly enhance superficial bacterial colonization overnight. And that perfectly illustrates the power of proper skin preparation. A single application of a concentrated alcohol-based antiseptic reduces the surgical site bacterial count by more than 95%. It's incredibly effective. But, and this is a major clinical warning, you absolutely cannot allow this fluid to pool on the patient's skin. If it pools, it can easily ignite with diathermy and cause severe burns. While we're looking at what actually works, it is crucial to follow high-level evidence for reducing surgical site infections, or SSIs. Surprisingly, there is zero solid evidence that drains, incision drapes, or wound guards actually reduce wound infections. However, there is absolute high-level proof that perioperative avoidance of hypothermia, keeping the patient warm, and the use of supplemental oxygen during recovery will significantly drive down those SSI rates. Now, moving from physical prevention to pharmacological intervention, we arrive at Module 5, antibiotic stewardship and prophylaxis. The value of prophylaxis depends entirely on the risk of wound contamination. For clean surgery, meaning no viscus is opened, the infection rate is naturally just 1 to 2%. So prophylaxis has pretty low value there, unless you're using a prosthetic implant. But look at the data for dirty surgery, procedures involving pus, perforation, or an abscess. Without prophylaxis, the infection rate is a staggering 40%. But with prophylaxis, it plummets to just 7%. That massive reduction is exactly what justifies a full 5-day course of therapeutic antibiotics for dirty procedures. But here's the catch. Prophylaxis only works if the timing is flawless. Ideally, it requires a single-shot IV dose right at the induction of anesthesia. The physiological goal here is to ensure that maximal blood and tissue levels exceed the minimum inhibitory concentration 90, or MIC 90, before the surgeon even makes the first incision. You repeat this at 4-hourly intervals during long operations, but note this final point very carefully. Further doses after surgery are entirely valueless. They do absolutely nothing to help the patient and only serve to promote bacterial resistance. Finally, we enter Module 6, Enogotic Properties and Formulary Profiles. This is a highly dense section where we're going to map out the specific mechanisms and targets of our pharmacological arsenal. Let's look first at the major cell wall inhibitors. Penicillins act on bacteria that are actively synthesizing new cell walls. Within this class, benzylpenicillin is fantastic for gram-positive pathogens. Flucloxacillin is resistant to beta-lactamases, which makes it your go-to for penicillinase-producing staphylococci. Now, if a patient is allergic to penicillin, cephalosporins like cefuroxime are alternative beta-lactamase-susceptible agents, though keep in mind they won't touch Enterococcus faecalis. Then we have the glycopeptides like vancomycin and teicoplanin. These are your heavy hitters for gram-positive aerobic and anaerobic bacteria, and they are specifically used prophylactically in high-risk MRSA environments. Shifting over to our ribosomal and broad-spectrum agents. Aminoglycosides, like gentamicin, act right at the ribosomal level to prevent protein production. They are incredibly effective against gram-negative Enterobacteriaceae and Pseudomonas. But, and this is a massive clinical correlation you cannot forget, they require strict serum peak and trough level monitoring to avoid severe ototoxicity and nephrotoxicity. Carbapenems give you broad-spectrum cover for serious mixed abdominal infections. Metronidazole is our absolute mainstay against all anaerobic bacteria, including C. difficile colitis. And lastly, ciprofloxacin is a potent quinolone, but its hospital usage is frequently restricted, precisely to prevent the development of C. difficile enterocolitis. Now, we have to connect all these pharmacological sensitivities back to real-world ward management. Most wound infections are endogenous. They come from the patient's own flora. But if you start seeing exogenous infections popping up across a ward and they all have identical antibiotic sensitivity profiles, you have an environmental outbreak on your hands. This demands drastic immediate measures: immediate swabbing of staff and surfaces, temporary ward closure, and an incredibly thorough deep cleaning. As we wrap up this explainer, I want to leave you with one final thought. From hitting a strict 6-hour sepsis window, to shaving skin at the exact right moment, to understanding the exact cellular targets of a glycopeptide, every single one of these details matters. So how does strict adherence to these highly specific surgical and pharmacological guidelines ultimately dictate patient survival? It's because out there in the operating theater, mastering and truly respecting these dense, interconnected protocols is your absolute ultimate defense against surgical disaster. Thanks for joining me today, and make sure you keep these principles at the very front of your mind.